GERD. GERD is not only the most common esophageal disorder, it's also the most commonly diagnosed GI disorder. GERD overall affects 15% of the general population. There is a definition called Montreal definition for GERD, which is reflux of gastric contents other than air, plus the classic symptoms of GERD, which are the heartburn and the acid regurgitation, or complications of GERD in the form of esophagitis or upper or lower respiratory damage. Epidemiology-wise, I remember there was a board question regarding the weekly GERD symptoms, but it was about 12%. So remember, 12 or 15% is your target answer here. GERD affects both genders equally. With age, GERD usually have less symptoms, yet more severe esophagitis. Overall, surprisingly, GERD people have normal acid secretion. You need to understand that reflux itself is actually a physiological phenomenon that occurs to vent the stomach and through the transient lower esophageal sphincter relaxation, through the inhibition of ileus and the diaphragmatic crura, and inhibition of the circular muscle of the body, along with stimulation of the longitudinal muscles. Usually it takes less than 1 minute and is triggered by gastric distension. And physiologically also it occurs less during sleep time and is mediated by the nitric oxide through an intact vagus nerve. Just to remind you, as we said in the first video, the LES is formed of the smooth muscles of the LES and the gastric sling fibers and the striated muscles of the diaphragmatic crura. As we said, the transient relaxation takes less than 60 minutes and it's a normal physiological phenomena, and it occurs to allow the venting of the stomach, and the main trigger is the gastric distension. Surprisingly, the frequency of this relaxation is equal in the normal and in the GERD patients. The obesity remains through the gastric distension is the main trigger of this phenomenon. That was all physiological. When you talk about pathology now in GERD patients, reflux occurs with more acidic contents more than air alone, and along with higher or more proximal migration of the reflux content in the esophagus. That will ends up with the esophagitis actually. Regarding the risk factors of the GERD, the main risk factors are obesity, hiatal hernia, smoking, and using of NSAIDs. The pathophysiology of GERD, you have 5 mechanisms. The first one is the loss of ileus barrier function, and again the most common cause is the gastric distension. The loss of the ileus tone through disease like scleroderma or Crest syndrome also lead to the loss of this barrier function. Also, the presence of hiatal hernia weaken the diaphragmatic crural augmentation of the lower esophageal sphincter. So throughout these 3 mechanical functions loss, you lose the ileus barrier function. Just keep in mind that the cardia is often submerged under the gastric contents, and during the recumbent position, especially the right lateral decubitus position, acids might leak from the stomach into the esophagus. Also, if you have any pathological condition that leads to the loss of the mucosal protective factors of the esophagus, that affects the squamous mucosa, affects the tight junctions of the cells of the esophagus, the buffering of the blood flow, the production of mucin, bicarb, and the growth factors. Loss of these factors will lead to repeated acid exposure and inability to wash out the acidic effect in the esophagus, and weakens the tight junction between the cells, leads to acid penetration and mucosal damage, and that might be visible or not on EGD. Decrease of the acid clearance along with the other gastric factors. We have here three different mechanisms: chemical, through less salivation, less mucin, less bicarb, mainly at night. That will lead to decrease the buffering effect of the swallowed saliva. An example for that is Sjogren syndrome, and using medications like anticholinergics. Any motility disorder, again scleroderma, crest, they will lead to ineffective esophageal motility, hypotensive LES, and inability to wash out the acid that has leaked into the esophagus and leads to severe GERD. Delayed gastric emptying, like pathological gastroparesis, gastric surgeries that might lead to bile or pancreatic or more acid reflux. All of these mechanisms might end up with injury to the esophagus. Increased acid production, like in ZE syndrome. Of course, if the gastric acidic content of the stomach is increased tremendously, like in ZE syndrome, that will lead to harmful reflux events that might lead to esophagitis. Again, obesity, we said it's one of the main risk factors through gastric distension. Gastric distension will lead to increase the LES relaxation and increase intra-abdominal pressure, and that will lead to GERD. Obstructive sleep apnea through a less sleeping time, so there's a less threshold to produce symptoms. There are some other miscellaneous factors like smoking, using beta agonist, calcium channel blockers, tricyclic antidepressants, thiophyllene, and all these affect the LES pressure and will lead to GERD. Also, pregnancy and its hormones will might precipitate GERD. Now, regarding the symptoms of GERD, symptoms are either esophageal or extraesophageal. Esophageal symptoms are classified into typical symptoms and atypical symptoms. The typical symptoms are the heartburn and the acid regurgitation. These two, if you are enough to diagnose the GERD if there's no alarm symptoms. The atypical symptoms, which are few of them have some alarm feature characteristics, like odynophagia and dysphagia, and angina like chest pain, hiccups, and water brash. Just remember here the mechanism of water brash is it's a reflux, hypersalivation, in order to neutralize the excess of acid. Regarding the extraesophageal manifestations, it's an important point here to understand how this extraesophageal manifestations evolves. It's either direct micro aspiration of acid into the respiratory system, or a reflux vagal nerve irritation at the distal esophagus. There are many extraesophageal manifestations. The only four well-established symptoms are the dental erosion, laryngitis, wheezing, and chronic cough. As we said, esophageal disease might have an alarm symptoms. These alarm symptoms will definitely change your plans regarding the diagnosis and management. So keep in mind, the alarm symptoms are the following. If your patient ages above 50, or he has or she has a typical symptoms of GERD more than 5 years, or there's dysphagia or dynaphagia or persistent vomiting, GI bleed or positive stool occult, iron deficiency anemia, weight loss, chest pain, lymph nodes or a mass, family history of upper GI cancer, or poor treatment response. All these are alarm symptoms or red flags. Again, elderly people usually have less symptoms of GERD, yet they have more erosive esophagitis. Why? It's because they have less pain perception. They have reduced sensitivity to acid reflux. You have to keep in mind when you about to diagnose GERD that there is a differential diagnosis that's important. Achalasia, zincodermaticulum, gastroparesis, gallbladder stones, peptic ulcer disease, functional dyspepsia, and angina. And remember that GERD is the most common etiology of non-cardiac chest pain. Regarding the differential diagnosis of esophagitis, GERD, pill-induced esophagitis, infectious esophagitis, and radiation esophagitis. Okay, regarding the complications, just bear in mind that complications are more in male, more in white people, and more with age. You have erosive esophagitis that have 5 folds of risk of Barrett esophagus. Esophagitis leads to GI bleeding. Just remember that erosive esophagitis is the etiology in 20% of patients with upper GI bleeding, and it's the most common etiology of upper GI bleeding in elderly or disabled patients. Barrett esophagus, there are 30-fold risk for adenocarcinoma and adenocarcinoma and peptic stricture. And reflux esophagitis is an etiology of iron deficiency anemia in all age groups.